Hi, everyone. Thank you so much for tuning into this webinar. I'm Priyanka Iyer, and I recently graduated from King's College London. I'll be starting my F1 job in Obs and Gynae next month in Northeast London. Abortion care is a topic that I'm quite passionate about, and I hope that you find this webinar both informative and engaging. So here's a quick overview of the two-part webinar series that I created during my virtual medical elective with Medics.Academy. This is the first part, where in the next 15 minutes, I hope to cover all you need to know about abortion care as a medical student. The second part in the webinar series looks at the UK law and a global health perspective on abortion care. So why did I choose this topic, and why is it important for medical students to learn about abortions? I have a personal interest in obstetrics and gynecology and women's health, and abortion care is a core aspect of women's reproductive rights. There's often a lot of stigma associated with the topic, which makes it even more important for us to educate ourselves on this. This topic is often only briefly covered during medical school, in women's health rotations, or during ethics sessions in preclinical years. As future healthcare professionals, it's so important for us to deliver compassionate and non-judgmental abortion care. And lastly, in cases of conscientious objection, which is where medical staff have the right to refuse participation in abortion for personal beliefs, we have a duty of care to our patients to be able to refer them on to other healthcare providers without causing undue delays. Here are some learning objectives that I hope to cover through this webinar. So we'll first look at some of the common myths associated with abortions. Second, look at medical and surgical abortions. And lastly, cover some of the practical aspects of accessing abortions in the NHS. I'm now going to present you with 5 statements, and I want you to take a couple of seconds to think about whether each is a myth or a fact. So the first, 1/3 of women in the UK will have an abortion. Second, if an under 16-year-old has an abortion, the family or caregivers will be told. The third, around 80% of abortions are carried out under 10 weeks. Next, abortion is safer than giving birth for the woman. And lastly, having an abortion can result in depression and infertility. So the first statement is a fact, and this highlights just how common abortions are. 1 in 3 women in the UK will have had an abortion by the time they're 45. The next statement is a myth, as if the young person is assessed as being competent according to Fraser guidelines, then confidentiality will be maintained and their family and carers will not be told. The third statement is in fact true, with 90% of abortions carried out under 13 weeks. Statement 4, this is again a fact, because when abortions are carried out in safe facilities and care is provided with trained professionals, it's one of the safest procedures that a woman can undergo. And lastly, as you might have guessed, neither of these claims are true. And it's really important that we reassure women about these when they're looking to end an unwanted pregnancy. So an abortion can be defined as the termination of an unwanted pregnancy. Before an abortion, you usually need to have an assessment appointment. And this happens either at the hospital or the clinic, but you may be offered either a phone or a video assessment. And during this assessment, you may discuss your reasons for considering an abortion. Women are offered the chance to talk things over with a trained counselor if that's something that's helpful. They get to talk to a nurse or a doctor about the different methods available, including any risks or complications. And if it's appropriate, they may also be offered an ultrasound scan to check how many weeks pregnant they are. And they might also be offered testing for STIs. And depending on any medical conditions or the stage of the pregnancy, they may be offered other tests, such as a blood test as well. And when women are sure that they do want to have an abortion, they're asked to sign a consent form. And it's important to reassure women that they can change their mind at any point up to the start of the abortion. So there are 2 main methods by which this can be carried out. And we'll now cover the first, which is a medical abortion. So as you can see from this infographic, a medical abortion involves 2 pills, mifepristone and misoprostol. I was taught of a really handy way of remembering the order that you take the pills. So Miffy has an F for first, and Miso has an S for second. So how do these pills work? The mifepristone is an anti-progesterone, which essentially ends the pregnancy. As you probably remember from your reproductive physiology, progesterone is pro-gestation. So it's absolutely vital, both in early pregnancy, where it helps thicken the line of the uterus, and later on in maintaining a healthy pregnancy. Once the pregnancy is terminated by the mifepristone, the next step is to contract the uterus to remove the pregnancy tissue. And this is done by the second drug, misoprostol. And as the name suggests, it's a prostaglandin, which stimulates uterine contractions. So the second pill is usually taken 24 to 48 hours after the first. And there are a variety of ways, including vaginal, buccal, which is where you place the tablet between the gums and your cheek, and also sublingually, where it's placed underneath your tongue. So with an early medical abortion, which is when abortions are carried out under 10 weeks, the abortion starts 2 to 3 hours after taking the misoprostol. Women experience vaginal bleeding, which is heavy with clots, and this bleeding can last up to 2 weeks, but the bleeding that follows is usually much lighter. They also experience lower abdominal cramping pain, which can be worse than period pain for most women. However, simple analgesia can be very effective for this pain. And lastly, most women complete their abortion within 4 hours, with almost all completing it in 24 hours. There have been some recent changes to guidelines, which have meant that women under 10 weeks of gestation can take the second tablet in their own homes, which allows them to choose a time that's most convenient and comfortable for them. With medical abortions over 10 weeks, there are some important differences and key points to remember. So repeated doses of the second tablet, misoprostol, is given at 3-hour intervals, and women are asked to come in for an inpatient stay. And 50% of women pass the pregnancy within 8 hours. If the pregnancy is over 20 weeks, so between 20 to 22 weeks, doctors usually recommend an injection of digoxin or potassium chloride to avoid the possibility of a live birth, which can be quite distressing for the woman. So the second method that women are offered to terminate their pregnancy is surgical abortions. And the procedure that they're offered depends on their gestational age. So if they're under 14 weeks, they're offered a vacuum aspiration. And if they're over 14 weeks, they're offered the dilatation and evacuation procedure. These procedures can be done under local anesthetic, under conscious sedation, or deep sedation, which is where women have to have a general anesthetic. So a vacuum aspiration is done either with a manual suction, which is this device that you can see now, or an electric suction device. And for these procedures, misoprostol is sometimes inserted into the vagina to help soften the cervix. And this makes the whole procedure much more comfortable for the woman. So after the cervix is dilated, the pregnancy tissue is then aspirated using the suction device. And the entire procedure takes 5 to 10 minutes, and women can go home a few hours later. If women are having a general anesthetic, they need to fast, and it's done as a day case procedure. Many women can go to work the following day if they prefer. Abdominal pain is minimal, and vaginal bleeding can last up to a week. So the second surgical procedure is dilatation and evacuation, which is done for 14 weeks and above. And as the name suggests, it includes dilatation of the cervix. So this is done either using the misoprostol, or you can use osmotic dilators. And essentially what this does is that it absorbs moisture from the tissue surrounding the cervix, and it swells, which then opens up the cervix slowly with little discomfort. The fetus and the placenta are then removed using forceps and vacuum aspiration. The procedure takes around 10 to 20 minutes, and it's usually carried out under sedation or general anesthetic. So both medical and surgical abortions can be carried out safely up to 24 weeks. What's the best method? And essentially, a lot of weighting is given to the individual's choice. For example, many women might not want to have an operation, or if they live with their parents, then an early medical abortion might be quite difficult. Their gestational age is also taken into account. And NICE has some really good clinical decision aids for women to help them decide between the two methods based on what factors are important to them. And I have a link to this at the very end of my webinar. So as we covered at the very beginning, if carried out in safe conditions by trained providers, abortions can be one of the safest procedures that a pregnant person can undergo. This table compares the risks of an early medical abortion versus vacuum aspiration. It's important to note, however, that risks increase in frequency and severity as the gestational age increases. When we look at complications of any procedure or medication, we can split this up into common or less common or rare. So common complications of terminations include bleeding and pain. To a lesser extent, infections can also occur. And it's really important to counsel women because if these infections are untreated, they can lead to pelvic inflammatory disease. And this can present as pelvic pain and infertility later on. Failure of the abortion is another complication. Extremely rare complications, which are specific to surgical abortions, are cervical trauma or cervical tears, which are under 1 in 100, and uterine perforation, which is again extremely rare, 1 to 4 in 1,000 procedures. So post-abortion care is equally just as important, and this should involve safety netting about when a woman should seek emergency help. So women are asked to get advice if they have pain or bleeding that does not get better in a few days, if they still feel pregnant after a week after the procedure, and if they have a temperature, flu-like feelings, or unusual vaginal discharge, because any of these could be signs of an infection. So the clinic essentially gives them a number of a 24-hour helpline to call if they're worried. And if they cannot find the number, they are free to contact their GP or 111. Another aspect of post-abortion care is a discussion about future contraceptive methods. And this is important as fertility returns quite quickly after terminating the pregnancy. So, practical aspects of accessing abortions in the NHS. Abortions, according to the law, can only be carried out under the care of an NHS hospital or a licensed clinic, and they're usually available free of charge on the NHS. There are 3 main ways to get an abortion. First, you can self-refer by contacting an abortion provider directly, and these are 3 of the main abortion providers in the UK. So you have the British Pregnancy Advisory Service, or BPAS, you have Marie Stopes UK, and the National Unplanned Pregnancy Advisory Service, NUPAS. Second, they can speak to their GP and ask for a referral to an abortion service. And if the GP has any objections to abortion because of their personal beliefs, they should be able to refer you on to another doctor without any delays. And the third is contacting a sexual health clinic, sometimes called a family planning or a GUM clinic. And they can then refer them on to an abortion service. So waiting times can vary, but women should not have to wait for more than 2 weeks from when they first contact an abortion provider. So just a few quick key points. So a third of women in the UK will have an abortion in their lifetime. 80% of abortions are carried out under 10 weeks. Mifepristone terminates the pregnancy, and misoprostol causes the uterus to contract. And both of these tablets taken together can successfully terminate the pregnancy. A surgical abortion under 14 weeks can be done with vacuum aspiration, and that over 14 weeks, a dilatation and evacuation procedure is used. And lastly, abortions are freely available under the NHS and can be accessed through the GP, sexual health clinics, and independent abortion providers. And just some useful resources. So this is one of the patient decision aids that are on the NICE website. And essentially you can see all the different factors that women can take into account, and they can basically weigh up which factors are very important to which factors are not that important to them. So it basically empowers women to have these discussions with their healthcare providers and thereby choose the option that works the best for them. And there's a lot of information on the NHS.uk website. Doctors for Choice is a really great organization for anyone that's really passionate about abortion care, and they do a lot of campaigning about decriminalizing abortions in the UK. There are also some really useful videos from International Planned Parenthood Foundation looking at how does medical abortion work and how does a surgical abortion work as well. And here are some references. And yeah, that's the end of the webinar. Thank you so much for tuning in, and I really hope that you found this useful. So please do have a look at some of the other amazing lectures delivered by my colleagues on a variety of topics. This lecture would not have been possible without all the support and guidance from the incredible Medics.Academy team. You can find out more about the Medics.Academy virtual elective in the link in the description box below. I would highly recommend signing up and taking part, as I had a really great experience on the program. Make sure you do check out part 2 of this video next, and you can also find a description to that in the box below. And again, please do like and subscribe to the Medics.Academy YouTube channel, as the content on the channel is constantly being updated. If you are a medical student, I definitely recommend signing up to the free SDocs program. If you have any questions, here's my Twitter handle and email, so feel free to get in touch. I've also left a QR code and link to allow you to provide feedback on this webinar. It shouldn't take too long, and I'd love to hear how you found this session. Thank you.